What's up, Ninja Nerds? In this video today, we're going to be talking about chronic myeloid leukemia, also known as CML. If you guys like this video, it makes sense, it helps you, please support us. And one of the best and easiest ways that you guys can go about supporting us to continue to keep making these free videos for you guys' enjoyment is by hitting that like button, commenting down in the comment section, and please subscribe. Also, you guys want some awesome notes and illustrations that I really think will help you guys to follow along with me during this lecture, go down in the description box below. There's a link to our website where we have some amazing notes and illustrations on our website. Go check that out. But let's start talking about CML. So with CML, very sad, unfortunate, but very interesting type of disease. And at this point in the lecture, really what I want you guys to understand is that when we talk about now going into the chronic leukemias, you guys should have already at this point watched the videos on acute myeloid and acute lymphocytic leukemia. Or in this case, we actually call them acute myelogenous and acute lymphoblastic leukemia. You guys should have watched those by now, and it's really important that you guys do because I think the pathophysiology at this point is really important to understand. Because if you guys remember, we have the hematopoiesis pathway, and CML is just an abnormality or alteration within the hematopoiesis pathway. That's really what it is. And it all starts with this beautiful cell, a pluripotent stem cell, or a hemocytoblast, which is the main stem cell located in the bone marrow that produces all of this downstream cell lines, which is pretty cool. So this is called the hemocytoblast. And the hemocytoblast is the stem cell for all blood cells. So what it'll do is it'll differentiate. And it'll differentiate to what's called myeloid stem cells, which you guys should already know by now, and then the lymphoid stem cells. And then what we talked about in AML and ALL is that really there was a disease process, there was something abnormal which was occurring in the next component of the cell line. Because what happens is myeloid stem cells, they'll further differentiate. When they differentiate in the presence of a hormone called EPO, TPO, which is erythropoietin, thrombopoietin, or what's called colony stimulating factors, these will then differentiate into specific cell lines, like red blood cells via erythropoiesis, platelets via thrombopoiesis, or making something called myeloblasts. And if you guys remember, in AML, the disease process occurred where? We'll write it down. AML occurred where the myeloblasts continued to proliferate, and you made tons of myeloblasts because it would proliferate, but it would not be able to differentiate into these further downstream cell lines. So it would not make functional white blood cells. Now, in patients who have CML, the disease process doesn't occur as high up where it kind of gets stuck in being able to replicate, but not differentiate. And this is where it's really interesting. So what happens is it's not here in the AML process. What's really weird in this process is that the myeloid stem cell goes haywire, and it just literally replicates like bunnies. And it produces a ton of myeloblasts, a ton of the next downstream effect. So we go to myeloblast into what's called a promyelocyte. Then we go into what's called a myelocyte. Then we go into what's called a metamyelocyte. And then these eventually go to what's called band cells, but they completely differentiate into what's called functional white blood cells called neutrophils. So you have your neutrophils, you have your eosinophils, and you have your basophils. And these are your granulocytes. The problem here is that the myeloid stem cell just over-proliferates. And if it over-proliferates, this thing is going to start going haywire. And if it goes haywire, it's going to increase its proliferation and produce more myeloblasts, more promyelocytes, more myelocytes, more metamyelocytes, and you make massive amounts of neutrophils, massive amounts of eosinophils, and massive amounts of basophils. That's really interesting, isn't it? So at each one of these, what's happening in really CML, or chronic myeloid leukemia, is this the myeloid stem cell that's just crazy proliferating, but it's differentiating into each step. Do you understand the difference? AML, it was going myeloid stem cell to myeloblast. Proliferate, never differentiated. CML goes here, proliferate, differentiate into specific granulocytes. So you'll get massive amounts of functional white blood cells, which is really interesting. So that's where the pathophysiology occurs in this particular disease. We're not going to focus on the lymphoid stem cell line because we'll talk about that in CLL, but you know the lymphoid stem cells, and the same concept, they'll go to become lymphoblasts, and then the lymphoblasts will then kind of further differentiate into T cells, and into B cells, or B lymphocytes and T lymphocytes. But in this particular process, the disease is occurring right here, the myeloid stem cell line, and it's just happily over-proliferating and producing multiple increased numbers of all of the myeloid stem cell line. And if you want to, even a little extra, sometimes for some reason, it may also increase the production of platelets, but it has no effect on the red blood cell line for some odd reason. But that is the big thing that I want you guys to remember. So now, the next question that has to come into your mind is what's the reason? That's the interesting component, right? So we know that CML is a myeloproliferative type of disease. It's that myeloid stem cell just replicating, and differentiating, and making tons of these white blood cells, and even some degree, platelets. Why is it over-proliferating? And that's the interesting question. One unlikely cause, but it's something to think about, is ionizing radiation. This may produce some type of mutation, if you will. But I would say that this is less common. So the reason why ionizing radiation may do this is it may potentially produce something called a mutation. And if you cause a DNA mutation, it may stimulate what's called oncogenes or proto-oncogenes. And it may inhibit your tumor suppressor genes and allow for these particular cellular replication to occur excessively without causing the cell to stop dying. So it'll have increased cell proliferation, and there'll be decreased apoptosis. So the cell won't die, and then it'll just continue to keep dividing. So that may be one reason. The more likely reason, and the thing that I need you to remember in this lecture, is likely genetic. And that's one of the unfortunate problems with this disease, is it's usually a genetic association. So the particular type of genetic association with this is it's seen in called a chromosomal translocation. And I'm actually going to remind you guys of this because you've seen it before. So chromosomal translocation is a really interesting type of process. It's where you're kind of like swapping genetic material between two chromosomes. And the two chromosomes that this is occurring in is called chromosome 9 and chromosome 22. So here's 9, here's 22, and you're going to have a translocation between these. In other words, there's a gene. Let's make it red. Actually, Rob, who loves to film these videos, he loves purple, so we'll do purple for him. This is going to be our gene right here. So there's one gene, okay? We're going to call this one our ABL gene. And then over here, we'll put this one, we'll say that this is like our BCR gene. What I'm going to do is I'm going to swap some genetic material. And when I swap the genetic material between these two, so let's show like a little swapping of genetic material between these two, what I should get is I should get something called the Philadelphia chromosome. And it really should be a combination of these two genes together. I fuse these two kind of genes right together and make them really abnormal. So look, now I have my fusion gene. So my ABL gene and my BCR gene are right next to one another and actually fused together. So this is the result of the 922 translocation. So the question that you have to ask is why is this bad? The BCR ABL gene causes excessive replication and inhibits apoptosis. The cell can divide, and never die. That's crazy. That's like vampire cells. So now from this, you'll have two particular effects here. One is you'll have excessive cell proliferation, as we talked about above with the ionizing radiation. And the other thing is that you will decrease apoptosis. The way that the BCR ABL gene does this is it activates this very specific enzyme that's involved in cellular proliferation. And I actually do want you to remember this. And the enzyme that it actually is kind of associated with was what's called a tyrosine kinase receptor. So it's usually associated with what's called the tyrosine kinase receptor, which is a very special enzyme. So I need you, please, for the love of goodness, don't forget that 922 translocation causes the formation of the BCR ABL gene, which leads to increased cellular proliferation, decreased apoptosis so the cell can divide and never die. And the main reason it has the ability to do this is it stimulates the tyrosine kinase receptor. This is 90% of the time associated with CML. That's pretty high. So the other disease, just to quickly test your knowledge, we said that this was seen with two diseases. One, CML. What's the other one? ALL. ALL. So it's 90% of the time associated with CML, 20% of the time associated with ALL. I know the math probably doesn't make sense, but that's the association relationship between these two. Now, question then comes, okay, is it's getting stuck where again? Just so we can remind ourselves, because what's interesting about CML is it's weird in comparison to AML and ALL and CLL, in that it has it's a triphasic type of appearance. So we said here we have what's called the myeloid stem cell coming from the hemocytoblast, goes into what's called a myeloblast, a promyelocyte, a myelocyte, a metamyelocyte, and then it goes and makes all of our granulocytes. We said that really what's happening is you're starting from this puppy here and you're just shunting these into this pathway, making lots of these, making lots of these, lots of these. In the initial stages, what we call there's a three-phase response. There's a chronic phase, an accelerated phase, and a blast phase. In the chronic phase, which is where 80 to 85% of patients usually live, you're actually accelerating this pathway and making tons of neutrophils, tons of eosinophils, and tons of basophils. But what happens is this only lasts for a certain amount of time, and as you continue to keep proliferating, what ends up happening, and this is what's weird, in the beginning it's due to the 922. Over time, as you continue to keep replicating and replicating and replicating, with every replication cycle becomes more mutations. With more mutations comes more abnormalities. So what I need you to remember is, as you continue this pathway, you'll have increased replication, right? But lots of replication that's occurring during this phase. But the thing that I need you to associate this with lots of replication comes increasing mutations. And with increasing mutations, you decrease differentiation. You decrease the differentiation of the myeloid stem cells. So now what happens is you start trying to push these into this pathway, but because it goes myeloblast, promyelocyte, myelocyte, it may get stuck here, or stuck here. And that's over time. So this is something that you see with time, and as the patient starts transitioning into what's called the accelerated phase or the blast phase, they have less of these functional neutrophils, eosinophils, and basophils, and more of the promyelocytes, myelocytes, metamyelocytes, less functional types of white blood cells. And that's important, and that's what we have to talk about next. All right, so the next component here in this lecture is talking about, okay, we've made tons of leukocytes, right? We've made tons of neutrophils, eosinophils, basophils, and they're actually pretty functional. We've just made a lot of them. And what was the reason why we made a lot of them again? It was because there was a mutation. It could have been due to ionizing radiation, or it could have been a mutation due to a fusion protein, the BCR-ABL gene that was formed, which was the 922 translocation, caused it to cause lots of tyrosine kinase receptor activity, causing excessive cellular proliferation, causing the cells not to die because it's inhibiting apoptosis. And because of that, these cells can live forever. And that's one of the downsides. And that over time, as you continue to keep replicating and replicating, with each replication cycle, you develop DNA mutations. Those mutations can then cause them to stop being able to differentiate. And we'll go through this progression. But one of the big things to realize is that in acute leukemia versus chronic leukemia, acute leukemia, a lot of these problems develop rapidly. So their cells actually do divide pretty rapidly. In chronic, it's more of a slow progressive process. So they do divide, but the problem with them is that they divide and they don't die. And so that's where the downside comes, but it's progressive over time, and then it can potentially get worse. So what's the effects of this? Let's talk about the triphasic response of CML. There's three phases: chronic phase, accelerated phase, and blast phase. In the chronic phase, which is where, to be honest with you, 80 to 85% of people usually present, these oftentimes have no symptoms. I'm not even kidding. Sometimes there's no specific symptoms. But if they do have symptoms, it's very, very vague. What are those symptoms? Okay, we know one of the problems here is that myeloid stem cell, here is that myeloid stem cell, it is just proliferating and producing tons of these neutrophils, eosinophils, and basophils, right? So one of the downstream effects that you'll see from this is if you were to get a CBC of the patient, you would have a massive leukocytosis. And the interesting thing is that this would be of all cell lines, and that's what's weird in this one. But it's actually very helpful, is that you will have a lot of neutrophils, which is relatively common, but what you don't often see is a lot of basophils. There's not many diseases that will pump your basophils up a lot. And I really think that that's worth remembering. So please don't forget that. It will pump up your eosinophils as well. Now, that's one thing, is that you may find this, and they may have strikingly high white cell counts on their actual CBC. So that's one thing that you could see, but I think the basophilia is really, really critical. But when you have these lots of leukocytes, what they may do is two particular things. One is that they can actually go and deposit into the spleen. And when they deposit into the spleen, the downstream effects of depositing into the spleen is that it causes the spleen to just get a little bit bigger. And this can cause something called splenomegaly. So you may see something called splenomegaly. And to be honest with you, this is actually one of the more common things that you may see that cause these vague features. Is that if you have an enlarged spleen, what's the spleen right next to? Your stomach. And so the spleen gets bigger, it's taking a lot of space and pushing on the stomach. Your stomach, you're supposed to get food in there. If you can't get food in there because it's actually being compressed, you end up with nauseous, you end up maybe even vomiting, you end up with you feel always full, or you have a poor appetite. So those are things to consider. So watch out for features of like nausea, vomiting, maybe anorexia or a poor appetite, and a sense of like abdominal fullness. These are really, really kind of key features that you can see associated with splenomegaly. And this actually tends to be one of the more common features that you see in the mild cases of this disease. Now, two things can actually happen with this one. Now, when you have this, these white cells, they can go to the actual spleen and it can cause the enlargement of the spleen, but it's not just because of them depositing into the spleen. It can cause the enlargement of the spleen by two particular factors. One of the reasons that the spleen enlarges is deposition. So the deposition of the actual white blood cells. But the second reason that the actual spleen enlarges is because some of these leukocytes cause the spleen to gain the capacity to start producing blood cells. They're like, wait, that's hematopoiesis. But it's not from the bone marrow. So we call that extramedullary hematopoiesis. So we call it extramedullary hematopoiesis. So that's what I really want you to remember, is that the reason why the spleen gets bigger is a twofold reason. One is because it deposits the leukocytes into the spleen, causing it to get bigger, but other is that the spleen gains the capacity to produce blood cells to help out the bone marrow. And this is called extramedullary hematopoiesis. Okay, the other thing that may potentially be there, and it's very mild, is that the leukocytes may release a lot of cytokines like interleukin-1, tumor necrotic factor alpha, things to this effect that may trigger these low-grade fevers. It may trigger some like fevers and some night sweats, but these are like mild constitutional symptoms. Okay, fevers and night sweats. So that might be something else that you can potentially see. But I really think the splenomegaly is key. The leukocytosis with the basophils are pretty key, and you may see some fevers and night sweats. The other thing is that it does affect the platelets. It has no effect on the red blood cell line. So what I want you to remember is that there's for some odd reason, no effect on red blood cells in this phase, because it doesn't actually cause them to, you would think, oh, the myeloid stem cells are responsible for making all blood cells, so red blood cells should go up. It's weird, there's no effect on them. But there can be an increase in the number of platelets. And so because of that, you do want to watch out for something called thrombocytosis, which may only be seen from getting a CBC. You might not see any of the potential features of thrombocytosis. So these are the big things that I really want you to remember about the chronic phase. In the chronic phase, the primary thing that you have to remember is most people spend most of their life into this phase. They usually present asymptomatic. If they do present with symptoms, most common it's associated with splenomegaly, maybe some constitutional symptoms. And if you don't see these constitutional symptoms or splenomegaly, oftentimes it's just something that you pick up from routine blood work, finding a markedly high white count on their CBC and a thrombocytosis. And again, to go back to the pathophys, just to make a little note of this, with that pathophys, what type of blast cells? So you're producing a lot of blast cells, you're producing a lot of white blood cells. One of the big things is that in this phase, the chronic phase, the blast cells are low. They are in the lower amount. We say less than 10%. Whereas all the other ones, all your granulocytes, the relatively mature ones, these are the ones that are in high amounts, okay? Lots of granulocytes, very little blast cells. But now, guess what? We go to the next phase. In this next phase, we got the accelerated phase. In the accelerated phase, what has now happened is you started this all off with the trigger. The trigger was likely a 922 translocation. And that was secondary to what's called the BCR ABL gene. And what that did is that caused two effects. One is it increased the cell proliferation, and the second thing is it decreased apoptosis, right? We know that. Now, one of the things here is that because of this lots of cell proliferation and decreased apoptosis, it really increased the number of granulocytes, right? It really increased the number of granulocytes. But here's the thing. If along the way, I add more mutations into the mix. So now what I'm going to do is I'm going to represent this with like a red arrow. I add more mutations. I'm going to put mutation here. Maybe from them having excessive amounts of replication, they develop a mutation in the P53 gene or a RAS gene, whatever it may be, and now they gain the capacity to start increasing more blast cells. So then they increase their granulocyte amount, but they also start increasing their blast cells. And it was less than 10% in the chronic phase, but now it goes up from 10 to 19%. And then we start having some problems, because now when you have a lot of these blast cells, you're starting to, again, you're still making a lot of these granulocytes, but it's starting to decrease a little bit. You're still getting a little bit less granulocytes, but you still have them. But now you're starting to occupy the bone marrow with a lot of blast cells, and that's starting to become a problem. So if I get up to 10 to 19% blast cells, I start to decrease the space in the red bone marrow. And what happens when you decrease the space in the red bone marrow? What do you do to your red blood cell line? What do you do to your platelet line? So you were proliferating them to try to make more platelets, but now you're hogging up all the space with 10 to 19% of it being blast cells. Those are big cells. Now you're going to drop your platelets and you're going to drop your red blood cells in this phase, the accelerated phase, where now there is more blast cells. This is what I really can't, please don't forget this. This is the big difference here between the accelerated and the chronic phase. Now, if I decrease my number of platelets and I decrease my number of red blood cells, what is this called? This is called anemia. And features of anemia may be evident by what kind of features? Pallor, dyspnea, or fatigue. Whereas thrombocytopenia is not the other feature. Thrombocytopenia, in the early stages, the chronic stages, it presents with thrombocytosis. But in the accelerated phase, now you have more blast cells. This is decreasing due to the decreasing space from the more blast cells, and decreasing space due to the blast cells, you're decreasing your number of platelets and decreasing your number of red blood cells. And now you end up with bruising and bleeding. So you can end up with petechiae, you can end up with purpura, you can end up with ecchymosis, you can end up with gingival bleeding, epistaxis, etc. And these are big things to be able to take away. Okay, so you may see thrombocytopenia in the accelerated phase, whereas you see thrombocytosis in the chronic phase. You see no effect with red blood cells in the chronic phase, and now you see anemia in the accelerated phase. The other component here is that you still are going to see, I told you, you're still going to have lots of granulocytes. It might be a tad bit less granulocytes that you had in the chronic phase, but you're still going to have them. So you'll still see a refractory leukocytosis, if you want to think about that. You'll still see a lot of these white blood cells. So you'll still have what's called a refractory leukocytosis. And I really don't want you guys to forget this again. You're going to have neutrophils, eosinophils that are high. But one of the interesting ones that stays high, and that's what's not common in many other diseases, is the basophils. When basophils are high, they release lots of histamine. And histamine causes agitation to the skin and you get really itchy. And so one of the features that you can see is you can see something called pruritus. So watch out for that, especially if the basophil count is high. So look for a refractory leukocytosis. With the refractory leukocytosis, the basophils will be high. That's not common in many diseases. So refractory leukocytosis, you're still going to have a leukocytosis in the accelerated and the chronic phase. You'll still have a basophilia in both of these phases. Pruritus might start to become a little bit more evident in the accelerated phase, not in the chronic phase. The last effect here is that you still can have like fevers and night sweats and things like that associated with the leukocytosis, but the splenomegaly becomes much worse. So these really start flocking to the spleen, and they really cause lots of deposition tons of deposition of more white blood cells, more extramedullary hematopoiesis. So I'm going to write this as extra hematopoiesis. And this causes this puppy to get big, man. You get some splenomegaly like a son of a gun, and then there's high risk of splenic rupture. And that is really, really key. So the splenomegaly continues to get worse in this particular phase. So splenomegaly gets worse with a high risk of now splenic rupture due to lots of deposition and lots of extramedullary hematopoiesis. So you can see now that when you cross over from the chronic phase into the accelerated phase, things start becoming a lot worse. And the reason why is because, yes, you're having a lot of these myeloid stem cells that are proliferating and making tons of these other cell lines, like especially the granulocytes. But the problem is that now you're starting to occupy more of the bone marrow with 10 to 19% of blast cells, where you didn't have that much in the chronic phase. And then if you start really kind of having a lot of these like cells here in the bone marrow, you start stretching out the bone marrow. And when you stretch out the bone marrow and expand that puppy, then you start causing something called bone pain. So watch out for that. And this should really be interesting because now you're starting to see features of something called acute leukemia. Am I right? Because in acute leukemia, there was anemia, thrombocytopenia, bone pain. There wasn't, like, the white count could be variable, right? But there was lots of blast cells, we remember that. So now we're gonna start seeing lots more blast cells in the peripheral blood than we would usually in the chronic phase. But this is starting to look like acute leukemia. That's when we go into the last phase, the blast phase. The blast phase is high mortality, my friend. Because at this phase, when you start having a patient who is in this phase, now they have transitioned from CML to AML. They now have an acute leukemia. You're like, wait, you can actually get that? Yes, because how do we classify acute leukemia? Acute leukemia was seen because it's the same concept here. You're gonna have that 922 translocation. That's gonna cause increased cell proliferation. That's gonna cause decreased apoptosis. With time and more replications, you're gonna get more mutations. More mutations then lead to increasing number of blast cells. You lose the ability to differentiate cells. When you have more mutations, you lose your differentiation capacity. They divide, but they don't differentiate. That should sound very familiar. That's acute leukemia. And so now the blast cells pump up and they get up to greater than 20%. That's AML. That's AML, my friends. And that is what's disastrous about this potential disease. Okay? So what I really want you to remember is that the mutations, they don't cause more blast cells directly, they do it indirectly because the mutations that you get here in this particular point here, what they do is they lead to a decreased differentiation. So now you can't convert the promyelocytes and the myelocytes and the metamyelocytes into eosinophils, neutrophils, and basophils. They get stuck in the promyelocytic stage, or they get stuck in the metamyelocytic stage, or they get stuck in the myelocytic stage, and they don't become functional white blood cells. And now you start seeing these blast cells in the blood. And that's the dangerous component of this disease. So now we get everything that we already talked about. Everything in the accelerated phase gets worse. Everything. Now, bone pain gets worse. This increases. Anemia gets worse. The thrombocytopenia gets worse. So you're going to get an increase in your anemia, increase in thrombocytopenia. Now you have less functional white blood cells. And you have increasing blast cells. And there's two effects here. If you have less functional white blood cells and increasing blast cells and decreased functional white blood cells, then you have a high risk of infection. And then you can start seeing things like pneumonia, UTI, cellulitis. And you know what else you can start seeing with lots of blast cells? All the oncologic emergencies. Like what? Like leukostasis. Like tumor lysis syndrome. all those fearful things that we talked about in acute leukemias. So that's really what starts to happen, is that what I really want you to understand, just to quickly recap, because this is why it's the toughest one to understand. Chronic myeloid leukemia starts off with 3 phases. A chronic phase, it's very asymptomatic. They don't really present much. Maybe just some splenomegaly and some leukocytosis with the basophilia. Some maybe constitutional symptoms. You don't have many blast cells though. So they're just making tons of like functional white blood cells. So they're good. They don't have infection risk. Then they develop more mutations over time. They lose their differentiation capacity. You start making less functional white blood cells. Infection risk does increase a little bit, but not crazy. But now you still have tons of white blood cells, a lot of basophils, which can cause this itchiness. You still start depositing them to the spleen, get more splenomegaly, risk of splenic rupture. But then you start dropping your other cell lines. Anemia, thrombocytopenia, you get bone pain due to expansion of the bone marrow because now your blast cells just jacked up. And then finally, in the blast phase, you turn most of those actual cells into blasts. Now you have so many mutations that have accrued that your blast cell component within the bone marrow has now increased to greater than 20%. That's acute leukemia. And now you drop all your cell lines, you have less functional white blood cells, thrombocytopenia, anemia, worsening bone pain, and now you have more blast cells than you did prior. Now you start seeing oncologic crises, tumor lysis syndrome, leukostasis, skin cell infiltration, and then because of having less functional white blood cells and more blast cells, you now have high risk of infections. So this is really the high mortality component because now you have all the downstream negative consequences. The next component is how do we diagnose this? When we get a CBC with a peripheral blood smear, it's a nice screening test because I told you, most patients, they live in the chronic phase. 80 to 85% of the time, they're in the chronic phase. So you're gonna pick them up in that phase. So when you get them in that phase, what would their red blood cell line be? Pretty much normal, right? So generally we could say it'd be 2 points. So let's say that it could actually be in 2 points here. So if we were to say, I'm gonna abbreviate this, let's say that we were in what's called the chronic phase of CML, it would be normal. But if we're in what's called the advanced phase or the blast phase of CML, then it would be a low red blood cell amount. So you would see anemia, okay? So that's an important thing to be able to remember. For the platelets, if we were in the chronic phase of CML, we actually see high number of platelets. So we see a thrombocytosis. But as the disease continues to progress and you get more blast cells occupying the bone marrow, taking up space, in the accelerated phase or the blast phase of CML, you start seeing a decreasing number of platelets. So that's really, really important. I need you guys to remember that. It's in the chronic phase and the accelerated phase, there is a difference in the potential findings. So in the chronic phase of CML, for the red blood cells, it could be normal. For the platelets, it could be high. In the accelerated phase and the blast phase for CML, the red blood cells could be low and the platelets could be low. The next thing is the leukocytes. That's really the key. You're gonna see in all phases, usually a chronic phase, accelerated phase, even maybe to some degree the plus, we'll put plus or minus the blast phase of CML, you're gonna see these crazy, crazy high white blood cell counts. And one of the big ones, you'll see increasing neutrophils. You may see increasing eosinophils, but one of the ones that will be a telltale sign and very helpful is you will see an increase in basophils. And I think that is super, super helpful. And these white counts can be like scary high. Like when you first look at it, you're like, oh my gosh, this patient's dying. And it's possibly, you know, that could be the case because these things can be up to like 50 to 200,000 white count. So that's usually pretty alarmingly high white blood cell count. The last thing here that I want you guys to remember is that you could see blast cells. You could see blast cells on the peripheral blood smear. But I think it's important to remember. So when you look at the peripheral blood smear, it really depends upon the stage. So generally, if you are in what's called the chronic phase of CML versus the accelerated phase or the blast phase of CML, in the chronic phase, you may see actual true functional granulocytes. So you may see a lot of granulocytes and really no blast cells, right? So you'll see very little blast cells. But when you get into the accelerated phase or the blast phase, then what happens is your blast cells start going up. And that's something that you want to be interested in, is if on the blood smear you find a lot of blast cells, that should make you think that you are in more of the accelerated phase or blast phase of CML. If you see less blast cells, that should make you think that you're in the chronic phase of CML. That's an important thing to be able to remember. So that takes us into our next component here. So we've done the CBC with peripheral blood smear. It helps us to kind of have an idea of what they would look like in the chronic phase versus the accelerated in the blast phase, right? We go to the bone marrow biopsy because at this point, let's say that we see a strikingly high white blood cell count with the basophilia, a thrombocytosis, a normal red blood cell count, and then let's say mature appearing granulocytes with very little blast cells. Then I'm thinking that this could be CML, especially in the chronic phase, which is where 80 to 85% of them live. I go to the bone marrow biopsy. You can do this, and it would help with your definitive diagnosis, but it's not absolutely crucial, but you can do this. And so you're going to take a piece of the bone marrow, zoom in on it. And when you zoom in on it, what you could potentially find is what we've already talked about. So let's say that here we look at blast cells, and here we look at them being a little bit more mature, like functional appearing. So if you see blast cells, you want to be able to quantify the number of blast cells that you see. If it's less than 10%, if it's 10 to 19%, or if it's greater than 20%. If it's less than 10, it's chronic phase CML. If it's 10 to 19, it's accelerated phase CML. If it's greater than 20%, it's blast phase CML, right? That's how we could easily go about this. Then what we want to know is there granulocytes? And what I would like to see is, I would like to see a mixture. Because in patients who have AML, they wouldn't really have a lot of like functionally appearing granulocytes. They wouldn't really have many of these at all. It could be variable if you gave, because remember what I said, you could have low amounts, you could have high amounts in AML. But in CML, that's what's really interesting, is you can see some actual true functional ones. Like you may see some true functional like eosinophils, neutrophils, basophils. You may see some that are like looking like myelocytes. You may see some that look like metamyelocytes. And so these are very interesting. You wouldn't really see any of these in AML. So if you see these, this is more suggestive of CML and way less suggestive of AML. And so that's why this is really important. If you see this, granulocytes, and you see a mixture of like functionally appearing mature ones, myelocytes, metamyelocyte, it's way more likely to be CML than AML, okay? But remember, once you start getting into the blast phase and you see greater than 20% blast cells, and on top of that, you start seeing maybe less of these functional myelocytes, metamyelocytes, you may have converted over into AML. So it's very important to remember. Okay, but the big thing I think the bone marrow biopsy is really helpful for is looking for blast cells and quantifying that to determine the stage, but also really helping to determine, is there a lot of granulocytes that appear like they're further down the differentiation process. If they are more differentiated, that's more suggestive of CML than it is of AML. I need you to remember that. Okay, once we've done this, we've found that they have any of these findings, and again, I would really like you to remember more the chronic phase, normal red blood cells, thrombocytosis, and a crazy leukocytosis with basophilia, likely mature appearing granulocytes, or at least some myelocyte, metamyelocyte on the peripheral blood smear, do the actual bone marrow biopsy to find how many blast cells they have to determine which phase they're in, and then do they have some mature appearing, highly differentiated white blood cells? That's likely CML. Then we go to the next step. At this point, if I have an idea that they have CML, then I just need to know, is it the type of CML that has the 922 translocation? 90% of the time, yes, but we need to confirm that because it determines what kind of treatment I will give them. So what I need to do is I need to take their DNA, put it into like a chromosomal analysis and find, do they have the 922 translocation that formed that BCR-ABL gene? If they do, that is important. Because if this is the case and I find this 922 translocation, this is going to give me the treatment which I will utilize. I will treat these patients with what's called tyrosine kinase inhibitors, which I'll talk about in a second. So that'd be the cytogenetic component. Then what I would do is I would take the chromosome and I would find where that BCR-ABL fusion gene is. So this was the 9, this was the 22, this is the translocation effect that we see here, right, from these. Again, what you're looking for is really this is called the Philadelphia chromosome, okay, chromosome. You want to be able to see this, okay? If that's present and they have that 922 translocation, then go to PCR and quantify, is this gene present, the fusion gene, the BCR-ABL gene, is it positive? If it is, guess what we treat these patients with? Tyrosine kinase inhibitors. And again, it's likely going to be the reason why, because 90% of the time, that's what it usually is. But you need to do this so that you can prognosticate and determine their degree of treatment. Because if it isn't this, you need to find out which other type of mutation they have, because they may offer a different treatment process. Okay, so at this point, we've confirmed the diagnosis of CML. We've found the specific type of chromosomal abnormality that's led to CML. Then what we need to do is we can add some additional tests, because sometimes, let's say that you only got a CBC with peripheral blood smear and you found that they had crazy high white cell count, and they also have an infection going on. There's two different things that can happen here. One is you can see CML, and the other one is you can have something called a leukomoid reaction. This is usually seen secondary to infection, or it can be secondary to stress. So like an actual stress in the body. Maybe they had surgery. Maybe they had some type of procedure done of some sort. Maybe they had a seizure. So it could be one of these particular things. But it's caused their white cell counts to go up. So their white blood cell counts go up, but they usually never break over 50,000. So they usually are less than 50,000. That's one particular thing. With CML, it's not secondary to an infection. It's not secondary to stress. It's usually secondary to a 922 translocation that's causing a malignancy to occur. And their white blood cell counts are very high, but oftentimes they're greater than 50,000. So that's one helpful thing. But what we also use is we use the presence of a specific molecule that can be found inside of these leukocytes. I'm going to represent it here in blue. And this is called leukocyte alkaline phosphatase. And what the leukocyte alkaline phosphatase is indicative of is it tells us, is this leukemoid or is it CML? That's all it does. And so when you look at comparing these two, that's really what you're using this for. And this can sometimes be utilized in exams. So in CML, there's not a lot of LAP, or leukocyte alkaline phosphatase. So the LAP levels will be low. Whereas in the leukemoid reactions, which are due to stress or infection, this is usually where their leukocyte alkaline phosphatase is very high. And that might be one way of being able to differentiate these two, which may come up on your exam, so make sure that you understand that. The last thing that you'd also want to do here is, again, if you have a patient who maybe is presenting with some vague symptoms, nausea, vomiting, abdominal fullness, anorexia, poor appetite, maybe some left upper quadrant pain, get an ultrasound or a CT of the abdomen. And if you do that, what you may find is this big enlarged spleen. What was one of the most common features that I told you on the chronic phase, which is really the only thing you can point out, splenomegaly. This is an important thing because you may be able to feel it a little bit on exam, but get the imaging to confirm that. So then what I would do is I would get some type of splenic ultrasound or a CT of the abdomen and find that actual splenomegaly. This is what it would look like. All right, my friends, so now let's move on to the next step here, which is the treatment of CML. All right, my friends, so now we're gonna talk about the treatment, and thank goodness it's actually not that bad. So when we talk about the treatment of CML, it's really remembering that what was the most common cause, the 922 translocation that produced the BCR-ABL fusion protein. Well, that was the real reason, because if you actually take a look, so let's say that here we take a look, because what I want you guys to understand is that the treatment, primary treatment for any stage, whether it be a chronic phase, whether it be an accelerated phase, or whether it be blast phase, the treatment for all phases of CML is what's called tyrosine kinase inhibitors, the TKIs. And if you guys forget these, there's two particular, so when we talk about these, the most commonly utilized one, so if we were to talk about these, the agents, the most commonly utilized one is going to be imatinib. But if you forget, just look for tanib. That's really the key way of being able to remember what was the TKIs. So really, what do these things do? Well, if you guys remember, let's say that we take here and we zoom in on one of these actual kind of like neutrophils or one of these actual like myeloid stem cell kind of tissues. What happens here is that here is your genetic material, right? Here is your genetic material inside. We're just kind of zooming in on the cell membrane and the nucleus component here. And what's happening is we said that there's two particular effects that's occurring from the actual kind of DNA component, is that we are activating specific genes that will increase cell proliferation, and we're also activating genes that will decrease apoptosis. And so this will cause the cell to replicate and never die, right? Which is crazy. And really the primary reason is that we formed a fusion gene. And that fusion gene was called the BCR-ABL gene. And so let's say here I represent this. Here's going to be this receptor. Here's this receptor here. This is called your tyrosine kinase receptor. And the tyrosine kinase receptor, when it actually has this BCR-ABL, so here I'm going to draw in like this blue color here. This is going to be the BCR-ABL fusion protein. So this is called your BCR-ABL protein. What this does is it goes and it actually fuses on to this tyrosine kinase receptor. And when it fuses on to the tyrosine kinase receptor, it hyperactivates the tyrosine kinase receptor. So when any kind of stimulus hits this puppy, it causes a hyperactivation, which goes and stimulates these genes to increase cellular proliferation and decrease apoptosis. And so then the cells continue to replicate, and don't die. So what if I came up with a way that I gave a tyrosine kinase inhibitor, and what I really did is I actually bound a drug to that BCR-ABL protein, and I inhibited it. That's what these tyrosine kinase inhibitors do. So really what these are going to do is these drugs are actually going to inhibit, they're going to bind to the BCR-ABL fusion protein and inhibit it from actually hyperactivating this receptor. Then you inhibit the signaling pathway, you inhibit the genes that are responsible for cell proliferation, so you shut this down, and then you shut down the genes that are responsible for trying to prevent apoptosis, and you actually induce apoptosis. And this is one of the ways that we can treat CML. Pretty interesting, right? That's the main way. Now, if patients fail tyrosine kinase inhibitors, then you can move on to something called a bone marrow transplant. So the other option that exists for these potential patients is you could do something called a bone marrow transplant. And this option is usually because it's secondary to failure of TKIs. The last potential thing that I want to talk about here is we can do something called cytoreduction. So obviously this would be one way, which would be the TKIs. But sometimes when patients have like these crazy high leukocyte counts and crazy like high thrombocyte counts, the problem is this can cause symptoms. And so when they start actually experiencing symptomatic problems, so symptomatic high white blood cell counts or symptomatic high platelet counts, then you should do cytoreduction. And we don't necessarily use TKIs. We actually use a very specific agent here, and this agent would be something called hydroxyurea. And this is helpful in really kind of knocking down your white cell count, especially when they are strikingly and alarmingly high. So this is another potential option. So I want you guys to remember hydroxyurea. If they have symptomatic high white blood cell counts and high platelets, you can consider hydroxyurea to really drop down their white cell count. But the mainstay of treatment is tyrosine kinase inhibitors. My friends, in this video we talk about CML. I hope it made sense. I hope that you guys enjoyed it. And as always, until next time.